Another high risk lesion, or a lesion that based on mammography is seen to be highly likely to be cancer, BI-RADS5 based on mammography. And the question was, how might elasticity imaging help here? Well, that patient was sent to ultrasound for an ultrasound guided biopsy, and the obvious question that comes up is, where's the back of that lesion? How large is that lesion? Where can I safely biopsy? Well, we see from the elasticity image the confines or the extent of that lesion. We can see that we can't biopsy deep into the lesion. We have to stick to the upper area of the lesion, as described by the elasticity image. So elasticity helps to define the lesion size much better than B-mode does, and can also be used in treatment planning. We see the same lesion in the perpendicular plane slid off the center of the lesion so that we don't see much evidence of the lesion in B-mode, but we see that in the elasticity image that we're still in a region of stiffness that is abnormal. So a reasonable question is, does this extend beyond just fibroadenomas and invasive ductal carcinomas? Well, a lot of the presentations that have been done in elasticity image focus on differentiation among solid lesions. One of the reasons is that we know that about 50% of all benign solid lesions are fibroadenomas, and about 85% of all cancers are invasive ductal carcinomas. So it's no surprise that they're the typical example. But do these same interpretation criteria apply to other lesions? Well, here's an example of an invasive lobular carcinoma where those same criteria do apply. We see that the size of the lesion in the elasticity image is quite a bit larger than it is in B-mode. And we also see that if we were to trace the boundary of that lesion in B-mode and then project that tracing into strain, we'd see a very different boundary than we see in the strain image. So the shapes are not the same, the size is not the same, indicative of cancer, same criteria. But solid lesions are only a part of the clinical problem. Benign versus malignant differentiation is important, but what about cysts? Can elasticity imaging help to differentiate cysts from solid lesions? Well, here's a small lesion that appears to be roughly 5 millimeters or so, embedded in what looks to be a normal background. But is it a cyst? Again, we measure its dimensions in perpendicular directions, 4 to 6 millimeters or so. In the opposite plane, about 6 millimeters, so it's a relatively small lesion. But is it a cyst? Turn on color flow, where we see no evidence of flow, but doesn't really give you great confidence that it's a cyst. But when we turn on elasticity imaging, we see the characteristic bullseye pattern that's common among cysts. And we also see an apparent strain enhancement behind the lesion. So one of the things that we know is that when we see this bullseye pattern, that's very likely to be a cyst. We can understand that by considering how that bullseye pattern occurs. We know that if we have a fluid-filled cyst, then we have generally fairly low signal amplitudes. And as a result, we have fairly low correlation from one frame to the next for the radio frequency echo signals that correspond to that data from the cyst. We also know that if it's fluid, the acoustic pressure can cause streaming, which tends to stir the fluid, so that we get, again, low correlation from one frame to the next. And that results in high apparent strain noise, and then if we use temporal smoothing or persistence, averaging a sequence of frames to generate one frame, that will result in an averaging of among those frames that have a fair amount of white in them that tends toward a high apparent strain or brighter than medium gray. On the other hand, around the perimeter of the cyst, but internal to the cyst, there isn't much motion, there isn't much decorrelation, and so the perimeter consistently looks dark. So we get a bright center surrounded by a dark ring on the interior of the cyst that generates a bullseye. I won't go into the details of that strain enhancement that's distal to the cyst, But our friends from Siemens explained that at a recent conference, and their explanation seems pretty robust. So we think that that problem is well resolved. To understand how well this information works, we did an observer study that involved 3 highly trained breast radiologists with a great deal of experience in breast ultrasound. And we asked them to do a variety of tasks looking at 100 different subjects, 50 that had cancers, 50 that had benign tumors. And so we had an enhanced patient pool, meaning more cancers than we normally would see in normal incidence, but that's to improve our statistics in the observer study. Again, we asked them to do several things, but the most important in terms of this study was to provide a confidence ranking of malignancy, view the B-mode image sequence, and provide some risk of malignancy. A rating of 0 would suggest that they believe there's no chance of malignant pathology. A rating of 100 would suggest that they believe they're completely confident that there is malignant pathology. And then they would look at that same data, but with B-mode and strain image information. And again, they did a number of things for us, but fundamentally, they reassessed their probability of malignancy after looking at the same data, but with B-mode and strain. The order of these was randomized among all the observers, so we did all the things that are necessary to perform a robust and reasonable observer study. But in the end, we applied receiver operator characteristic analysis, ROC analysis, on those confidence rankings to determine how well the radiologists performed at assessing risk. An ROC curve plots the true positive fraction versus false positive fraction, and the area under the ROC curve is a measure of performance. We plot here the data for B-mode data alone as the blue curves and B-mode plus strain as the red dashed curves. And the first thing that you see is that the red dashed curves in each case lie above that for the blue curve. Same is true when we combine the data to get an average observer performance. So the area under the curve is always increased when we have B-mode plus strain information over B-mode alone. When we combine that among the 3 observers, we get a statistically significant increase for the combined observer in their ability to assess risk based on B-mode plus strain information compared to B-mode alone. So from that study, we can say that elasticity imaging information adds new information that's not otherwise available, and that information helps radiologists to assess the risk of breast cancer. We also know from this study and our practice of a number of human subjects that the method for obtaining a high-quality elasticity image is not necessarily the same as it is to obtain a high-quality B-mode image. High-quality elasticity images are typically obtained with minimum surface pressure, transducer just barely in contact with the skin surface, not pressing hard enough to flatten the tissue layers out. We also know from that work that elasticity image information can help us to better define the size and shape of a lesion, which should improve treatment planning.